This is Dr. Charles Parker, and you're listening to Core Brain Journal. It's a place where I connect both fresh discoveries and interesting different perspectives from advanced mind science with the realities of real people and everyday life down on Main Street. So welcome aboard, folks. Dr. Charles Parker here at Core Brain Journal, and we have a very interesting guest today, Dr. Joel Young, who is on the same path that many of us have been on for a long time, trying to find answers about all the variables, the complexity of what's going on with executive function and ADHD. So welcome aboard, Dr. Young. We're really pleased to have you.
Well, it's my pleasure. Thank you so much for inviting me.
So what we're going to do is just do a brief word here from our sponsors, a little intro, then we're going to get started, and then we'll have a little break later on to hear more about them. As you listeners already know, we just love the reality of data here at Core Brain Journal. And today we welcome our clinical friend and our new sponsor partner, Direct Health Access Laboratory. With over 3 million studies, they are deep leaders of experience with the big picture of measuring, for example, methylation, cryptopyrrole, and copper challenges, and much more. They provide a global service with a molecular focus. Stay tuned, more later. And then you also know how much we appreciate detailed improvements with mind care on a more residential structured level. So today we're pleased to welcome this additional sponsor and partner with a deep interest in fresh options to address the complexity of adolescent treatment failure nationally and internationally, and is built TRICARE friendly. The Barry Robinson Center provides holistic environment right down here in beautiful downtown Norfolk. It sets children, teens, and families on the path to a more comprehensive, structured healing process. From personal experience down here, I know their work with families that we've actually shared together. They're a truly different residential experience, more in a moment. So now I'm going to give you an intro for Dr. Young. He is the medical director and founder of the Rochester Center for Behavioral Medicine. As the medical director of RCBM, Dr. Young provides care to patients across the lifespan. He's very broad in his thinking, and he's very comprehensive. One of the reasons I really wanted to get him on, so he could talk about his perspective about the complexity of ADHD through the lifespan, what we know, what we should know, what we don't know, and what we need to know next to actually do the best kind of job. So he was the first director of psychiatric emergency services at Crittenden Hospital. And while working with RCBM through these years, he served as Crittenden's chief of psychiatry staff and maintained staff privileges at the hospital there in Detroit. So let's talk a little more about his clinical interest, which involves the treatment of attention deficit hyperactivity through the life cycle, as I was saying. He also specializes in treatment-resistant depression. He's probably strong on the homocysteine theory of depression, which we won't go into right now. He has researched and published on chronic fatigue syndrome and fibromyalgia. He oversees all treatment taking place at the Rochester Center for Behavioral Medicine. He has apparently about 40 staff that work with him there, so he's got a big, very active clinical practice doing good work up in the environs of Detroit, Michigan. So he's also a clinical professor, associate professor of psychiatry at Wayne State University School of Medicine, and he works also with family medicine residents to do their psychiatric rotations. So that's a very lengthy but very comprehensive, interesting bio on a guy that's covering the bases in so many different levels, both academically and on the street level. So if you would, Joel, I didn't ask your permission to call you Joel. I hope you're okay with that.
Be my pleasure.
All right, so I'm going to be Chuck. I didn't really get that done because we were jumping to get on this conversation. Joel, tell us a little more about yourself. I mean, we've covered some items there, but let's really let the audience know about who you are personally, what you're doing, what your mission is, and where you're going with your life up there outside of Detroit.
Well, thank you for, again, inviting me, Chuck. I'm a psychiatrist and a clinical researcher. We're actually outside of Detroit in Rochester Hills, Michigan. And so basically my day is composed of taking care of a lot of people with various psychiatric challenges, from anxiety, depression. I have a particular interest in ADHD through the life cycle. So we take care of a lot of people in a team approach using multimodal approaches, biological psychiatry, psychosocial interventions, and we do it kind of in a coordinated way. And then I spend a lot of my time doing clinical research. We do close to 100 trials over the years in various novel medications in disease states varying from anxiety to fatigue to smoking cessation, et cetera. So when there's data needed, we're usually one of the sites that's involved.
Very interesting. So tell me this. What do you think, from your perspective, all the work you've done, what would be, if you were going to hone in on something that the public needs to know, that's actually remarkably persuasive to you, that's sort of in this age of innocence, which I do think there's a considerable amount of innocence going on regarding medications and diagnosis and treatment for ADHD, what would be your main focus of something you would say, hey guys, this is something we really need to focus more carefully on, do it more thoroughly, and be more aware of this overlooked, underappreciated aspect of attention deficit disorder, executive function?
Yeah. Well, it's interesting. So I think if you talk to 100 different clinicians, everybody seems to be interested and intrigued by particular things, and sometimes they vary by small degrees. I've been interested in my career, now it's getting to be 25 plus years doing this, is the natural history of ADHD. We've nicely identified what this disorder looks like in children, although that's really evolved over the past generation too, understanding inattentive symptoms, not just hyperactive symptoms. And so I think we've done a pretty good job carving that out and understanding ADHD in children and maybe early adolescence. I'm actually a geriatric psychiatrist. That's where I got one of my board certifications. And so I'm just naturally interested in what happens in the third and fourth and fifth and sixth and seventh decade of life. What does ADHD look like? And I'm gratified to say that although when I started thinking about this in the early 1990s, there was a small group of people, and now there's a lot more people thinking about it. I certainly was not the first. But I've been intrigued by the natural history of ADHD. And of maybe particular note where I try to write about and focus on is what happens to inattentive symptoms as people age. And what I have found is a subgroup of people develop chronic fatigue and even chronic pain syndromes. Again, this is inattentive ADHD folks as they age. And it's this natural history which medicine is always interested in. What do diseases become as people age that has intrigued me? And I do believe that chronic fatigue and fibromyalgia can be conditions which develop later in the course of inattentive ADHD.
That's interesting.
Yeah.
So you see the ADHD and the complexity of being disorganized and with executive function as having a downstream effect on other somatic activities, not just mind activities.
Well, yes. So I would say that as a psychiatrist, that very, very involved, I see a lot of people, and I listen carefully. I do like to listen. And when you do that, as you know, Chuck, people tell you stories. And after a while, you start to hear similarities in their stories. They're different because everyone's experience is different, but there's some commonalities as well. And what people tell me who come in very frequently, I'm usually not the first clinician or even the first psychiatrist they've seen, but they tell me, I've been diagnosed with depression and I've been on various antidepressant medications. Doctor, I've been on Zoloft, and I've been on Prozac, and I've been on Effexor, and I'm not sustaining a response. I was okay in the beginning, and I just can't continue to feel better. And then I'll ask the question, so what are you really hoping for? And often they will say, I don't feel motivated, I don't feel organized, I know what to do, I can actually instruct my children what to do, but I have a hard time doing it myself. And then when you hone in a little bit more, they talk about being poorly motivated. Certainly, as you mentioned, having executive dysfunction, problems getting started, staying focused, staying organized. But it's this lack of motivation, we call it an amotivational syndrome, that people often talk about. And my observation has been that particular presentation, I'm fatigued, I'm not motivated, I can't sustain my activities, and it doesn't respond to antidepressants. That's when I start to think that maybe ADHD or inattentive ADHD could be the explanation.
Mm-hmm. Yes.
So a few years ago, you asked me what maybe I'm most content with, was a study that I did and published. And we looked at about 26 people at our single site in Rochester, Michigan, who met criteria for chronic fatigue syndrome. We really didn't ask them if they had ADHD. We just recruited them if they met criteria for chronic fatigue syndrome, which is persistent fatigue, persistent lack of motivation that doesn't have another explanation, like anemia or chronic disease. And actually, there's a number of these people out there. It was not the most difficult study to recruit for, because there are people who really feel poorly and want to come in to a clinical study. And so we could accommodate about 26 people in our site, 13 of whom received placebo, and 13 of whom randomly were assigned lisdexamfetamine, which is known as Vyvanse. And we did this in a double-blind fashion, and we found quite conclusively that when given the standard ADHD medicine compared to placebo, individuals had better cognition, they had improved executive function, and they had less fatigue compared to those on placebo. And it's this study which I would like to duplicate. I'd like to see it in a bigger study. That has been one of my contributions that I'm pleased with.
Well, thank you so much. Now, let me ask you this, because this is one of the reasons that I really wanted to have you on, because I heard a little bit of this when you were talking to Jeff Copper, and I wanted to take it further down the road, because we wanted to get into a number of different things, because I quite agree with you, and this is not in any attempt to steal your thunder. I've been doing this and seeing this happen repeatedly, but I didn't have it tied up specifically with chronic fatigue in that manner, because what I think happens, and I would like to ask you, and I'm not really trying to put you on the spot, I'm just trying to have an open discussion about this. It seems to me that I recall somewhere along the line that the actual formation of dopamine and serotonin had something to do with similar neurotransmitter evolution variables, where if one was enhanced, the other one just dropped down based on that shift in the mechanisms. Can you talk about that at all?
I don't think I'm the proper person to do that.
Okay.
I think that's more of a basic science. I think I could swing at that and probably miss, and I would probably defer to, neurophysiologist in that regard.
I just see it clinically, and I was just thinking, because you do the research, I thought you might be able to address it, but you are talking about some of the same things that I think a lot of people in the country do see, and I'm so glad you're doing the research on it, because it's really kind of not in the literature sufficiently for people to think about it preemptively. It has to walk in the door and just really present in a macro way, instead of looking at the subtlety of that situation and the pervasive quality of that presentation.
Right. So I think your question is really good. Obviously, as a clinician, a clinical researcher, I am, speaking for myself, seeing the gross symptom management. Everything probably can be reduced and should be reduced, to what's going on the neurochemical level, and that is a developing story that I think you are the far greater expert on. But as a phenomenologist, as a clinician, I certainly see these folks, and I see them to be frustrated. I think they feel a little bit alienated. I feel like a little bit left behind. I would put these patients often in a category of treatment-resistant depression.
Mm-hmm.
And what I have found is actually if you ask the right questions and do the proper screening, many of these folks may have depression, but that's not a sufficient discussion. Just kind of tickling with the serotonin system is probably insufficient for these folks. And so comprehensive diagnosis, which I know has been something that you've talked about and written about, is also my mantra. And so I think when patients come in and they're distressed, we should evaluate them for major depression. We should evaluate them for anxiety disorder. We should evaluate them for substance use disorder in a comprehensive way. And we should not leave out that probably 10% of the population, at least 8 to 10% of the population, has ADHD. What I have been vocal in my way, as have you, Chuck, is that ADHD probably doesn't go away. It is a persistent disorder, and it seems like adult psychiatrists in some ways have jumped ship on this. They've turned the other cheek and somehow don't take a really good developmental history. It's as if life begins at age 18, and it doesn't. It begins early on, and whenever we're interviewing a 25-year-old, we want to ask about their developmental history. We want to ask about their academic history. We want to understand their executive functioning, and that's what good old diagnostic psychiatry is about.
So true. I think one of the things, Joel, and I'd be interested in your reaction to this, but I think one of the reasons that people don't do the assessment is I think we have a deficiency regarding the structure of the diagnostic system that exists independent of the kind of questions. It's really hard to ask the questions if you don't have the criteria clear, because actually what happens with ADHD, it's so often diminished in terms of a phenomenon that's observable behaviorally, whereas the actual presentation of executive function is much more cognitively determined and oftentimes quite hidden from behavioral appearances. And so that's part of the problem. Go ahead. You were going to say something.
Yeah, no, I agree with that. Somehow I think our default diagnosis, however, has become depression. And so we, in some ways, half-kiddingly, but actually pretty seriously, when a patient is in our waiting room, we call them distressed. Because that doesn't infer a specific diagnosis. We don't call them depressed because that does. And I think that with the advent of serotonin reuptake inhibitors, now they're very available, they're very affordable. I think if somebody shows any sign of distress, the default diagnosis is depression. And I see this all the time. People coming out of the primary care setting is that it's almost hard to walk out of an office without a prescription of sertraline or fluoxetine or something. And I think that's not a bad guess, but but psychiatry should take a page out of neurology. Neurologists historically have been diagnostically driven, and we have some great traditions that they can learn from, but that's one tradition that psychiatry can take from neurology. And I think I agree that although the diagnostic criteria is imperfect, it's a work in progress, and what we have is okay. We just have to ask the questions. We have to do the rating scales, and it has to be on our radar. And I see that it's not. And I think if it were, I think we'd have a lot less treatment-resistant depression, a lot less treatment-resistant anxiety.
Well, let me ask you this question, and I'm just looking at the time, and I think what I'm going to do is ask you to answer the question when we get back. We'll have a little break for sponsors here, but here's the question I'm going to ask when we get back. The issue is when you get into dual diagnosis. Let's take a moment for you, because you've seen so many people and you've been on this theme for a long period of time. What do you do in terms of dealing with individuals who are actually having problems with medication in the first place? They don't want to take medication. And here you as a professional coming in, you've done the good work, you've made the diagnosis, and you say, okay, now they need to take 2 medications. So and after a little break, I'd like you to say, how do you actually handle that with a patient, and how do you explain? Because that is the ubiquitous problem that we all see. So we'll be back in just a minute, folks. Well, you folks already know that here at Core Brain Journal, we're on a mission to introduce you to resources that make significant contributions to the investigation of those predictable mind science applications. Our colleagues at DHA Lab Group provide a real difference with treatment options for people at every level, from first awareness of mind problems to those frustrating times when even well-informed treatment becomes surprisingly unpredictable. For my entire professional life, from psychoanalysis to brain scans, I've searched for, yes, improved predictability. The good news for all of us, from professionals to patients, remarkably effective research offers useful, cost-effective, organic options far beyond guesswork with psychiatric medications alone. DHA lab tests measure unbalanced biomedical details through easily available testing, now available globally for a variety of molecular answers from, for example, methylation, copper, and cryptopyrrole challenges. Check in for more details at dhalab.com core. That's dhalab.com/core. Well, folks, you know as well as I do that psychiatric treatment failure, especially after multiple medication trials and those very, very brief hospitalizations, may prove insufficient to deal at home with the complexity of troubled children and those adolescents from 6 to 17 years old. Improved care, those next mandatory steps, should include a more comprehensive approach to address those multiple levels of challenges, from family to peers to school, diagnostically from defiance to depression, on every level for families, including military families internationally. The Barry Robinson Center's 32-acre open college-like campus in Norfolk, Virginia, provides safety and security and clean, comfortable living. How do we know? We refer folks over there all the time, strongly endorse what they're doing. So for further information, an informed interview, connect at this page, barryrobinson.org/core. Okay, Dr. Young, we're back. So I don't mean to put you on the spot with that, but I'm sure you do this almost reflexly because
Yes.
It's such a commonplace problem. But I did want to share and ask you to give your observations about that next impediment, which is going to be an additional reason to not even go into the diagnosis, because you do have to deal with it. What do you do and how do you handle that?
Yeah, I think it's a really interesting question and a sensitive question that, when we as clinicians do this routinely, we almost, in one way can get desensitized to the fact that often part of our answers are medication-based. And although it becomes routine for the prescriber, just like it's routine for the surgeon to cut open a belly, it's not routine for the patient to be prescribed. It's an invasive modality, medications. These are brain-based medications, and you're right, Chuck. Patients are often ambivalent about it and conflicted, and whether in Norfolk or Detroit. So that's a universal response. I think as a clinician, as a humble doctor, I try and educate my patient. I say, this is what I think. I think, in the hypothetical patient that we're talking about, I often will say, this is probably, you've had a partial response to an antidepressant. I think in this case, if you have ADHD, I think that could help explain your inconsistent motivation, your fatigue, some of your executive dysfunction, symptoms which have persisted despite being on the antidepressant, and I am suggesting a second medication. I'm not demanding it. I'm not expecting it. I'm making the suggestion. So I sometimes tell patients I'm like a pitcher. I'll pitch it. You decide if you want to swing it.
No, that's a good one. I like that.
Yeah.
I'm totally with you, putting the patient in control so we can have really an evolution in participatory medicine. It's the reason really to be speaking with a professional like yourself regarding really the democratization of neuroscience for the public, because the public needs to know about these things. And I'm so appreciative of your sharing it. I think it's a great way to say it, because we really do want the individual patients to feel responsible for their own care and report back to us whether we got it right or didn't get right, and really stay with us in the program. So that's a good little story. Please take a swing at it.
I will add to that is so I completely agree, and this is really part of your mission on your webpage is this idea of participatory medicine and really giving access to patients so they know what the latest thinking is. One of the things I hear when I have that observation to see different cities and travel throughout the country and the continent is how frustrated people are with access to care, and particularly access to ADHD care. I'm wondering if that's something that you've seen or something that has been a theme that you've discussed. Do you think patients have good access?
No, Joe, we share that one entirely, and it's the reason for us to have this conversation, because it's so mysterious and there's so much consternation about using stimulant medications in the first place, and there's so many people writing for stimulant medications with really having a diminished sense of what the targets really should be. I mean, it's just great to hear a guy like you who really has a sense of the complexity of the presentation and what the targets actually are and how the medications should work in the first place. I mean, so often people come back and say, is it working? And the patient has no idea what the criteria are for what working is in the first place. So, yeah, I think it's a very important point.
I agree. I will say that we have one advantage, though, because, again, I talk a lot to medical students and resident physicians and other doctors, and we're all concerned, whatever our specialty is, adherence to our patients actually taking the medication as we prescribe. And, of course, if you and I were hypertension specialists and we were interested in blood pressure management, we'd have the same conversation. If we are diabetologists, we'd be talking about insulin control. So I think it's things that doctors talk about. We know what best practices are. We just sometimes don't think our patients will follow them. Having said that, I think in psychiatry, and particularly ADHD psychiatry, we have an advantage. And the advantage is if you make a good diagnosis and you use proper medications, patients feel better, and they often feel better quickly. They might have a harder time describing exactly, and sometimes they need our help in articulating their response. But when they stop taking the medication for ADHD or depression, they feel it. They know it. There's a built-in sensor. They start not to feel well. Whereas if you stop taking your medication for diabetes or blood pressure, it might be weeks, months, or sometimes even years before you recognize the loss. Mm-hmm. So we have some advantage, and that's why I think our compliance rates are kind of comparable to some other disease states. Because if you stop taking it, and it's been helping you, sometimes our patients, it's been my experience, appreciate the meds more in their absence than in their presence.
So true, especially if they have comorbid chronic fatigue and fibromyalgia. I mean, they are going to somatically appreciate what's going on, because whatever's going on cognitively, it seems to, I think, accentuate the appreciation of having insufficient medication on board.
So you are always somebody who brings it from the clinic to the bench, and so I think there is some theory that there is theory that these medicines, these stimulant medications, which we seem to play such a pivotal role in ADHD treatment work primarily on dopamine and norepinephrine. And with regard to fibromyalgia or chronic pain, it's my contention that many folks with ADHD cannot filter out stimulus, even painful stimulus, muscle pain, lower back pain, atypical migraine, etc. They can't filter it out, even tinnitus, even ear ringing. And people without ADHD can just naturally filter out the stimulus. And that is thought to be a dopamine issue, that dopamine can help filter out extraneous stimulus. In psychotherapy, we think a lot of our ADHD patients are chronically overwhelmed by their life, but they can also be chronically overwhelmed by their pain. And that's where the fibromyalgia and ADHD story, I think, takes place. Now, we don't have any indication for this at all, but this is one of the areas of great interest to me, is that if you treat somebody with a stimulant and you enhance dopamine levels, you can allow them to filter out extraneous stimuli and focus on more positive stimuli. And that's the whole issue of distractibility, not just on a psychological level, but on a physical level as well, that people can stay more focused and less distracted on the negative.
Joel, that's very interesting. I hadn't thought about that before. I hadn't thought about that functional component before. But that's,
right.
Now that you say that, intuitively sounds very correct, because it just makes sense. It's a commonsensical point that I really hadn't considered before, and I know others may not have as well.
Yeah. So psychiatry then, if these theories do add up, then we need to do the proper studies, and clinically where I sit doing clinical trials, it would be nice to get a multi-center study doing this. I did theoretically prove it in one site, but science has to be replicated, and it should be done in multiple sites without a biased approach. You try and do it as unbiased as possible, and I think you can't evaluate your own child, really. You have to have other people evaluate your child. So this is my theory, and I'm hoping, as you asked me earlier in the broadcast, what I hope to pursue, I hope that we can look at some of these conditions like chronic fatigue, chronic pain, perhaps as psychostimulant responsive conditions. And I'll abide by the answer. If it's a negative study, we drop it. If it's a positive study, we have to look farther. But just as you have always said, that this is the journey of neuroscience. Maybe some of these other conditions that we have, psychiatry has not embraced, chronic fatigue, muscle pain, chronic pain, which might lead to opiate addiction, by the way. Psychiatry might have to embrace that these might not be disorders of the periphery, disorders of the muscles, but it might be disorders of the brain, the way the brain perceives pain. And so I think this is why neuroscience just needs total attention.
Well, and it addresses the complexity of the presentation. I mean, there are many other aspects, as you well know, of variables that are present, but this is a variable that is very frequently overlooked. We see people coming in, as you've so accurately pointed out, who don't know what to do with themselves, who have had these chronic medical conditions for a long period of time, like fibromyalgia and chronic fatigue. And really, until this conversation with you, I hadn't really thought about that manifestation. I hadn't really said to myself professionally, hey, here's something that we need to really think about and really dive into the executive function portion of it and be more accurate in the treatment, so that we're not just looking at this as another depression condition, derivatives of another depression condition with downstream somatic imbalances.
Right. But it might answer a lot of questions. For instance, it's hard to watch any news broadcast today. Well, we know it's dominated by a lot of other things, but when there's a public health story right now, it's an opiate story, that we have an opiate crisis in this country, which means we have a chronic pain problem in this country. And we now know that opiates are not the answer. I was trained in the early 1990s, and at that point, long-acting opiates were in vogue, and we found that to be a disaster. We have found that to be a public health disaster. Mm-hmm. But that doesn't mean the problem of chronic pain has gone away. Mm-hmm. And so we now know that we don't have that option, and we know that is a disastrous option, and so we have to rethink these patients, and this is a public health issue because I think if you're unmotivated or inconsistently motivated, you have a hard time getting going in the morning, you're underproductive, you're more likely to be underemployed or unemployed, and you're more likely to end up on disability. And one way of being on disability is having a chronic medical condition. So there's a ton of folks out there who are suffering. We don't know what to do with them. They need some type of disability payment or some type of help. And so they get a diagnosis of a chronic pain condition. And then once the opiates are introduced, it's really hard to back off. I'm thinking that ADHD might be part of this story. And it just speaks to the complexity of this disorder over the lifespan. It's one of the few conditions that starts, in infancy, or it's certainly in the latency years, and probably doesn't really give up until our last day. It looks different through the life cycle, but it's I think a persistent problem.
Quite so. Now, let me ask you this question as we wind down a little bit here. Do you have any specific preoccupations, if you will, and that's perhaps an excessive way of saying it, but nevertheless, preoccupations regarding specific medications that you, as a professional studying these variables that we're talking about, would think would be preferable regarding a medication for comorbid ADHD in individuals with comorbid pain, chronic fatigue syndrome challenges. Do you have any preoccupations in that regard?
Yeah, so the study that I did do, again, it never received an FDA indication. It was just a study, a published study, looked at LDX or lisdexamphetamine, marketed as Vyvanse, as an excellent agent. But that doesn't mean some of the other mixed amphetamines or amphetamines, preferably longer acting, wouldn't be equally as good. The study just happened to be on LDX. So I think, in my estimation, it's, as you've covered, we have two big classes of stimulant medications, the methylphenidate and the amphetamines. As a profession, we've moved by and large to long-acting agents because there's less of an abuse potential, less diversion. Mm-hmm. But of the two, methylphenidate versus amphetamine, I would say the amphetamines seem to be a little bit more essential in this complex comorbid discussion that we've had, where people have chronic fatigue and, say, a depressive condition. So,
well, thanks for weighing in on that. That's a touchy subject, Joel. I mean, I didn't want to put you on the spot with that, but I quite agree with you, and I just thought I'd hear your unencumbered view before I got into my own personal experience. But I appreciate your saying that, because everything you're saying it matches my own clinical experience with individuals who are chronically impaired, that those longer acting medications are better. It seems like they're easier for a person to manage. And if there's no contraindication to using them, they're easier to manage medically with a person, because the criteria and the, as you said a moment ago, the abuse potential and the ability to dial them in effectively and correctly, efficiently, is improved upon with the extended release, because you don't have that PK value fluctuating so much through the day. Pharmacokinetic, the way the body burns it is pretty consistent, so that you don't have people chasing chasing the ups and downs through the day with the immediate release medication. So I quite agree with that.
Yeah, I think it's easier on the patient, and it's also easier on the doctor, because if you prescribe something and you say a long-acting once-a-day medicine, hopefully you can get away with once a day. That's not always the case, but once-a-day medicine, then you see them back in 30 days, you can make the assumption that if the denominator is 30, if they've had 30 attempts, that they're going to be, their batting average will be 50%, hopefully closer to 90%. But if you give them a medicine that they're supposed to take every 4 hours, that means the denominator is 90. And how many people can take 90 pills a month and continue that ad infinitum? It's unrealistic. I have a few patients who are more compulsive who are able to do it, but most patients aren't. I know I'm not compulsive, and so I think compliance is quite much better. So you can actually make, as a doctor, I think you can make a more informed clinical judgment if you use long-acting medicines.
And your outcomes are going to be more consistent, absolutely. Well, Joel, thank you so much for taking the time. It's a really interesting conversation. I really haven't had a chance to speak with you before. I really very much appreciate it, and I know our audience appreciates having somebody weigh in who's done the research, who's spent the time thinking about these various comorbid conditions with ADHD on a more complete and more thorough researched level. I mean, it's great, and we really appreciate you coming on board.
Well, thank you, and thank you for your contributions to the field and your vibrant blogs and webpage. So I appreciate
thank you so much. Now, before we close, let's leave a little note where people can connect with you, so we give them an opportunity to chase you down if they have a need to follow up.
Well, I'd be delighted. My website is rcbm.net.
Mm-hmm.
And we have a pretty good website. It's interactive, and if people want some information about some of the work that we've done, or they need to get in touch with us if in their area, then it's rcbm.net.
Thank you so much, Joel. We'll send them over there. Will be published probably in about 2 weeks, and we'll keep you posted and let you know when it happens.
It was my pleasure to join you today.
Thank you, sir. Thanks for being on board. Thanks for listening to Core Brain Journal. We're working every day behind the scenes to bring you reports that connect research benches with those street trenches. Here we share the complexity of mind science because, as you know, details really do matter. One of the most pervasive, misunderstood challenges is how commonplace medications, like those written for ADHD, are used so regularly without clear guidelines. If you think you'd like more specifics, take a minute to download my 2-page PDF packed with video links and references on the absolute essentials of how to start ADHD medications. They're easily available at corebrainjournal.com/start. Thanks for listening. Do connect and stay tuned. Together we can make a difference.